Good evening, everyone. Welcome to this second NZUSI postgraduate teaching class. And as we know, this year also because of COVID-19 pandemic, our all exit exams for MCH and DNB postgraduates will be virtual exams. And therefore, we're trying to train them in this style of exams, online mock exams, so that they can do well in their actual exams. So today, we have two young and dynamic moderators and three very senior esteemed teachers who have joined us for this mock exam. And I will start first by inviting our our president of the NZUSI, Dr. Sudhir Rawal sir, to please give his welcome address. Dr. Rawal sir.
Thank you, Anup, and I welcome you. This is second of this kind of mock exam, and the second wave is now coming down, and hopefully things will improve. But the future is still bleak because we don't know what will happen in the future, whether third wave will come or it will not come, or it will be weak third wave or very strong third wave. So with that in mind, I think mock exam like this, they help our PG to continue learning and about the, at least urology teaching goes on. As one joke is there on WhatsApp nowadays that the people, the MS guys in this pandemic area, will they get MS degree or medical MD degree? So that should not happen with us because we are working hard, and in urology we have always been very enthusiastic in teaching, and our students are one of the best in the medical fraternity who come to urology. So that learning continues like this in the pandemic era. So with that, I welcome you all for this second master class, and I hand over back to Anup.
Thank you very much, sir, for your kind words. Now, I will request our USI president, Dr. Mallikarjun sir, to give his welcome address.
Thank you, Anup. I think it's more a customary talk of mine, but I think it's a fantastic work from NZUSI, what you're doing about the mock exams. I do echo the sentiments of Sudhir. What he said is, what is going to happen about these people who have joined recently or a year ago, pre-COVID at times, into the USI, into the urology field? How much amount of training they might be losing? It's going to be a big question to be answered in near future. Possibly we may be training for a good mock exams and training for some amount of teaching, but I don't think hands-on experience is getting beaten up by the COVID pandemic. And anyway, it's nobody's hands. Nobody can do anything for that. But I think I request all the residents to garner as much amount of time as possible to get trained in the short period. Though there may be an extension of their total duration of training in many of the DNB courses, I don't think that may be good enough or sufficient enough to train them completely. But anyway, these programs do help them in training themselves better, not only for the exams, but for being a good urologist too. And I congratulate you for continuing these programs during this tough times. Thank you very much, Anup. All the best to this program.
Thank you very much, sir, for your encouraging words. And we always need the support of USI as a parent body to keep doing these kind of activities. And then I will request now our honorary secretary of USI, Dr. Keshav Murthy sir, and he has been very active in doing these kind of activities throughout the different corners of the country online. And I would request him to give his opening remarks.
Thank you, Dr. Anup. And it is very good that the North Zone USI has taken the lead and is continuously doing this. This is the second session in 15 days, maybe. That's the way, because you have to train the people. As Mallikarjun was telling, that we are concerned about the trainees not getting good amount of hands-on workshop, hands-on training. So we need to devise something to see that their training continues, because we are not very certain about what this disease, how long it's going to last. And especially people who have joined in last year, if you see 1 year, their hands-on training would be very small amount of surgeries they would have done because of the COVID situation. So we are actually from the USI ISU planning to have a session with select faculty and the residents to understand what is the problem, so that the USI can write to the apex bodies, the NMC and the DNB, to look into these issues on surgical training, for at least for surgical specialties. Hands-on training is very important. For the medical specialties, you can train them by online, or this training can go on. But for the surgical residents, it's not very easy. If it goes on for 2-3 years, their training is completely lost. How do we compensate for that? We need to discuss about this shortly. We will call a session on that. And with this note, I would congratulate the North Zone for doing this, and all the best for this session. Over to you, Anu.
Thank you very much, sir, again for your encouraging words. And as we know, last year also NZUSI under the leadership of Dr. Amlesh Seth sir started this program. We did 4 such programs, very well appreciated. And this year, on our request of our postgraduates, we have done 1 such program 15 days back. It was very well attended and appreciated. And that's why we are planning to do at least 4 or 5 such programs before the students actually have their final exit exams. So this year we have the leadership of Dr. Sudhir Raval sir. And we are very confident that this year also we'll keep doing all kind of resident activities. So for this activity we have 2 moderators, Dr. Sujoy Surekha, and he is the additional associate professor in SGPGI Lucknow, and Dr. Sudhir Kumar Diwana, associate professor from PGI Chandigarh. Both are very dynamic surgeons and have a very good passion in the academic activities. So they will be presenting 1 case each, and we have 3 esteemed teachers. All these teachers do not need any introduction. The first one is Professor S.K. Singh sir. He's the head of Department of Urology from PGI Chandigarh. He will be joining very shortly. Then we have Professor Amlesh Seth sir. He's the HOD of AIMS Delhi and also our immediate past president of NZUSI. And then we have Dr. Shivam Priyadarshi sir. He's a HOD of SMS Jaipur and also our president-elect of NZUSI. So we are really privileged to have such esteemed teachers who have taken their precious time to teach and train our young urology students. So I will start with the first. Now we'll hand over to Dr. Surekha. So we have 3 students in 1 group, as we did in the last activity. 20 minutes each student will get the time to take the viva. So we can start with the first case, and over to Dr. Surekha. He can now start sharing his screen.
Thank you, Dr. Anup sir, for giving me this opportunity. I will share my screen now. I think sharing is not open, right?
Okay, so audiovisual, please allow him to share the screen. You can make him co-host so that he can share his screen.
Yes, sir.
Okay.
So the first student who will take the viva is Dr. Sagar. So please be ready to keep your audiovisual on and use earphone if possible, so that we can have clear audio from your side.
Yes, sir.
Am I audible clearly, sir?
Yeah, please go ahead.
Right. So, Dr. Sagar, can you hear me?
Yes, sir.
Yeah. So the first patient is a 60 years old gentleman who presented with complaints of voiding and storage lower intake symptoms for last 1 year. And he predominantly had voiding symptoms. So with this piece of history, what are the various differential diagnoses is likely to come in your mind, so that you can subsequently further go ahead with more positive and as well as negative history?
Yes, sir. So first is benign prostatic enlargement with LUTs. Second is, sir, vesical calculus. Third, sir, maybe CA prostate. And fourth one is, sir, maybe, sir, CA bladder malignancy. And fifth is stricture urethra.
Bladder calculus. Why did you say bladder calculus? What is in this to suggest a bladder calculus?
Sir, as patient had a voiding predominantly voiding complaints. Maybe
So
he had, sir, poor flow.
how
Or
frequently in your 2-3 years,
yes,
how
sir.
many times have you seen a 60-year-old male coming with lower urinary tract symptoms and diagnosed to have a bladder stone?
So it is less common in this age. It is mostly, sir, secondary stone after the benign prostatic obstruction forms in these age group patients, sir.
You kept that at number 2 in the list. Is there anything in this that suggests a bladder stone?
No, sir.
Okay, tell me. So if your diagnosis is bladder stone, what kind of a history are you going to elicit to tell you whether it is likely to be a bladder stone or unlikely to be a bladder stone?
So it is in this age group, it is less common, sir.
No. My question
Yes, sir.
is, you have now made a diagnosis of bladder stone.
Yes,
So
sir.
what kind of a history or what questions in history are you going to ask to come to a conclusion whether it is likely to be a bladder stone or unlikely to be a bladder stone?
Sir, I like to elaborate the symptoms of the patient, like ask about the poor flow of urine, intermittency, he has to strain or not, and there is symptoms of incontinence or symptoms of
So these are the questions that you'll ask from all patients who present with lower urinary tract symptoms.
Yes, sir.
My question is a limited question. What are the specific questions that you are going to ask in case you suspect that the patient has a bladder stone?
Sir,
Or in other
sir,
words, what type of history do you normally get in a patient who has a bladder stone? If
sir,
I frame the question in another way. Yes.
yes, sir. Sir, he had maybe he had history of stone disease in the past, and
Okay,
some.
so which means that if he has a history of stone disease in the past, then he's more likely to have a bladder stone now. Is that what you are suggesting?
No.
Sagar, which type of stone would you think that would have more voiding symptoms? What is the site of the stone?
So if it is a obstructing the urethra or the bladder neck, sir.
So why did you say bladder stone then, vesicle? You should have told either a posterior calculus or something which would cause more of voiding symptoms, right?
Yes, yes, sir.
If you are thinking about voiding symptoms. And what in a bladder stone, what is a typical symptom that usually the patient presents with? A very typical symptom. And there is a term to also this symptom, name to the symptom.
So he had symptoms of.
Have you heard of strangury?
Yes, sir.
Right. So
yes,
typically
sir.
the bladder, sometimes it will obstruct the bladder neck area, and again it will cause difficult pain during micturition and difficulty in micturition, a typical strangury symptom. So you're not getting these symptoms in this patient. Probably has a voiding and storage symptoms and not typical of a bladder stone, right?
Yes, sir.
You said about the bladder malignancy also.
Yes,
What
sir.
are the how did you suspect a bladder malignancy in this patient?
Sir, if there is any large growth which obstructs the bladder neck area, then it causes the voiding symptoms, or irritative symptoms are present when there is a CIS changes present in the bladder.
Yes, so it could be a simple carcinoma in situ which can produce such symptoms, but how many cases of bladder tumor you have seen producing just presenting with voiding and storage symptoms only? Bladder tumor, large bladder mass. You said that they're causing obstruction and then causing these voiding and storage. Have you come across any of such patients, which is causing only voiding symptoms, and there is no hematuria, nothing, large bladder mass.
Yeah. Sir, mainly they present with the sir complaint of painless hematuria, sir, and followed by the sir voiding or irritative.
So how can you say a large bladder mass can present only with the voiding or storage symptoms? It could be carcinoma in situ, definitely, yes.
Yes.
Yeah.
Okay, Sagar. Okay, this is a class. This is not an okay. It's a mock exam, but okay, I'll still tell you the answer that I expected. You can imagine what is happening during the act of micturition in a patient who has a bladder stone. Most of these patients would be having a stone behind the prostate in what is called as the Bass pond, or a cavity kind of a thing, or a some kind of a urine collection area basin that is found behind the bladder. And intermittently, the stone may come and fall in the passage or may obstruct the passage. So the obstruction may be intermittent. And at the time when the obstruction would be there, towards the end, the patient would have a spasm of the bladder and pain, which may be referred to the perineum or the tip of the penis.
Yes.
Okay, this type of this kind of a symptomatology is seen more common in small children with bladder stones, but in adults also this can happen. So an intermittent obstruction and significant increase in the discomfort at the end of micturition, these are two symptoms which will tend to point towards the presence of a bladder stone. Okay. Okay, now my second one, coming back to the question of bladder stone. Out of 100 cases of BPH that you have seen, in how many have you seen a bladder stone?
Sir, in 5 to 10 cases only, sir.
Okay, so it is not that common. So you should not keep it that high in the list of differential. Yes, it can be there, but a little lower down. Okay, we'll go ahead now. Let us go ahead.
So the differential diagnosis which you have missed probably is also bladder dysfunction. It may be neurogenic or non-neurogenic. You don't know. Patient complaint only of lower intake symptoms. So this area you have missed. So this should have been your part of your differential diagnosis. Definitely.
Yes.
Otherwise, you will miss some percentage of patient.
In fact, he has not taken a full history still. So
I'll go, sir. What additional history do you want to know? So I'll go next.
Yes, sir.
The complete history is very important.
What additional history you want to know further?
Yes, sir. I like to ask about patient had any complaint of dysuria, any complaint, any history of suprapubic pain or suprapubic lump, and any previous history of retention, acute urinary retention, history of any catheterization or instrumentation, and also history of any hematuria in the past or not, history of flank pain, lithuria and graveluria, any history of spinal trauma or spinal surgery in the past. And I also like to know about the any history of the abdominal distension, any history of jaundice, bone pain, weight loss, loss of appetite, and cough hemoptysis.
Sumit, tell me one thing. In a 60-year-old man with these symptoms, what is the commonest type of neuropathic bladder that you have come across? In the list of differential diagnosis, that number 5 is neurogenic and non-neurogenic bladder. Okay.
Yes.
So now
yes,
my question is, in a 60-year-old man, if I tell you that this is likely to be a neuropathic bladder, I somehow or the other have some kind of a extra vision, and then I tell you that this is likely to be a neuropathic bladder. What is the commonest cause of neuropathic bladder in this kind of a setup in the community?
So it is.
Can you think of any systemic illness which can cause neuropathic bladder?
Yes, sir. So diabetes mellitus patient may have history of
very
diabetes
good.
mellitus.
Yes, that is the question that I'm asking you. But in the list of questions, so far you have not asked any question whether the patient has diabetes mellitus or not.
Yes, sir.
Okay, so you do have to elaborate all the lower unit tract symptoms, but
Yes,
is yeah, okay.
So what I suggest that you should have a history, you should have a very focused approach. Otherwise, you will miss a lots of history. So as per your differential diagnosis, you should take a positive as well as negative history. So like lower intake symptoms, details of lower intake symptoms. Hematuria is one important aspect. You should take details history of hematuria. So according to a differential diagnosis, you should categorize it and you should take history one by one. Otherwise, you will miss some or other history. Right. So
Yes.
go ahead.
The history is still not complete.
Right.
This is what you are
Yes,
saying,
sir.
the present history. You would
Yes, sir.
ask anything
I-
about that? Yes.
Yes, sir.
Go
I
ahead.
also like to, sir, ask about the past history of any chronic disease like hypertension, diabetes mellitus, tuberculosis, any previous surgery, history of any previous contact with that, any contact with the tuberculosis, or I like to ask about the personal history. He is married and how many children, and any history of addictions, and diet of the patient, and work of the patient, and duration of the work, and also I like to know about the family history of the patient, sir.
So you have missed a few important points in the history. Yeah, one, you didn't ask about the personal history about addictions like smoking, alcohol, and the drugs he might be taking. And the drug-induced urinary symptoms is one of the very common causes for urinary symptoms, right? So you didn't take a drug history of the patient, and then you didn't take a bowel history of the patient, because bowel history is again very important. If you think you're thinking in terms of neurogenic bladder or non-neurogenic, or even the urinary symptoms could be aggravated with bowel problems. So I think these things are again very important, which you missed in the history. So what do you think after taking this history? So now this is the history. Yes, go ahead.
Yes, sir.
Right. So as suggested, you have missed the important history of constipation as
Constipation.
pointed by the expert. So at the end of the history, does your differential diagnosis list or order remain same, or it will alter?
Sir, I like to sir, see the previous slide also, sir. Yes, sir.
So the previous slide only has a IPSS score, which is 23.
Yes, sir.
So, right?
Yes, sir.
So
And
23 means what?
Yes, sir.
What does 23 mean?
So it means it. See, he had a severe symptoms, sir.
Okay.
Yes, sir.
So next slide, go ahead. And the positive thing on the next slide is
Sir,
hypertensive.
hypertensive, and sir, patient has just drink occasional drinker, sir.
So would you like to know exactly which drug he is on?
Yes, sir.
Does it make a difference?
For hypertension, it is not, sir. In yes,
No,
sir,
sir. Is there a drug which can cause more of urinary symptoms? Antihypertensive drug?
yes, sir. If he is on diuretics,
Right. So if it's diuretic,
yes,
or even
yes, sir.
hydrochlorothiazide is attached to that other medication, definitely the symptoms could be aggravated.
Yes, sir.
Anyway, so this is drug history is again very important. And he's
Yes,
a
sir.
social drinker also, though he's not
Yes,
a
sir.
chronic alcoholic, but it's a social drinker. Yes.
Social drinker. Yes, sir.
And he is a constipated. Has a constipation also.
No history.
No
of
history of.
No history of constipation. Fine. So now tell us the diagnosis. Any change in the differential diagnosis now?
Yes, sir. So my first differential diagnosis is, sir, benign prostatic enlargement with LUTS. Second is stricture urethra. Third is, sir, CA prostate, sir.
So again, you think stricture urethra without any history of any infections, STDs, any history of instrumentation, any history of catheterization. Still, you think stricture is the second probable diagnosis in a 60-year-old male?
What specific history you would like to get elaborated by the patient when you think of a stricture urethra?
Sir, history of, sir, any external marital affairs
No.
or sexual contact. Yes, yes, sir. And sir, history of urethral discharge patient had.
It's not called as
Anything else in
extramarital affair.
presentation? Now, again,
Had
giving
its
you hint.
exposure.
Anything
sir.
in presentation. Patient is symptomatic for last 1 year. If it
Yes,
is a
sir.
case of stricture urethra, how the symptoms will progress? Can you elaborate on that point? Can you get that information from the patient? If you are thinking of stricture urethra, he's symptomatic for last 1 year. You are thinking of stricture urethra. What pertinent question do we like to again ask the patient, so that at least you can have some supportive thing? Because there is no history of instrumentation, no history of catheterization, no history of trauma, no history of sexual intercourse or extramarital contact and discharge. So what history will again let you think of at least stricture urethra is one of the differential diagnoses. Stricture urethra, does it progress with the passage of time? How is the stream? Thin stream or it is a normal stream? The stream can be weak in cases of
Yes, sir.
BPH. How will be the stream in cases of stricture urethra? Is the disease
Sir,
progressive or it remains stationary? Okay.
sir,
There is a very specific question that is mentioned in the book,
yes,
which
yes, sir.
if you ask from the patient, will help you distinguish between BPH and stricture urethra. What is the question?
Sir, I'd like to ask for the flow of the urine during the straining.
Yes,
As the patient strains, yes, sir. The in BPH, the stream becomes more poorer. Yes,
So the patient has to relax to improve the case. Okay.
yes, sir.
So go ahead.
So this patient had progressively worsening lower intake symptoms in spite of alpha blocker, which is not written in this history.
Yes,
So the
So
differential
what else
diagnosis,
would we do now? What next?
right? What
So
next?
you would go ahead with an examination, right?
Yes, sir. And yes, sir. I like to examine
Okay,
the
what
patient.
examination you want?
So,
Sir,
sir,
I
here,
like
sir,
to
we
check
want
the.
to change. So we want to change the student now. So I think Dr. Manzoor can take over. Dr. Manzoor, you can.
Yeah.
Hope your audio
So
is
new
allowed.
yeah.
Good evening, sir.
Now, yes, new questions to Dr. Manzoor. Yeah,
Yes,
in
sir.
the history, so long-standing again obstructive symptoms in the patient.
Yes, sir.
I am just giving you a hint to make it again. Yeah, Dr. Manzoor.
Yes, sir.
Yes, Dr. Manzoor, you have joined?
Yes, sir. I joined.
Yeah, you are online. Now, just in this particular case, when this patient is having symptoms, severe symptoms for last 1 year, now I'm giving a hint to again formulate a question. Now,
Yes,
this
sir.
may be having some upper tract changes. Might be. We don't know.
Yes.
Can you tell any history which may be relevant in this case, whether that has happened or not? Back pressure changes causing something will have some manifestation. Would you like to ask this patient like that?
So any history of flank pain or recurrent UTI?
Okay, you couldn't get it. Back pressure changes. Can
Yes.
it take something which becomes
Sir,
obvious when you ask the history? Okay.
Sir, any history of
Doctor,
mass? Any history of mass in the flank, sir? Swelling in
Okay,
the
so now
flank.
you are telling, okay, now. So now any history of loss of appetite, nausea, vomiting,
Yes, sir.
maybe pedal
So that I
edema,
will do.
that right. Okay,
Yes,
so
sir.
right.
Yes, sir.
Okay.
Sir, actually, we have to rule out the upper tract changes, sir. Back pressure changes.
So one is the
Proceed.
back pressure changes by swelling or lump in the abdomen, and by the symptoms, uremic symptoms
Yes,
are
sir.
there or
Yes,
not.
sir.
Right?
Yes, sir.
Secondly,
Yes,
which patients could be of this type? How would you differentiate a chronic retention patient?
Sir,
Suppose,
a chronic retention patient will be passing the urine, but he will be having a painless, palpable bladder, even after passing urine.
okay, so every patient of a chronic retention actually passes urine, voids urine, or what is the typical?
Overflow, or patient can have overflow incontinence, or they can have a post-void residual more than 300 ml.
Okay, so these history are important. Now I think we came back from physical examination. Okay, so let us proceed now.
Yes. So,
What you would like to know in physical examination?
Sir, in general physical examination, I would like to know whether his general condition, whether is his performance status, his facial appearance, any lymphadenopathy, cervical, or any pedal edema, scrotal, any swelling in the scrotum, or ascites.
see, Manzoor, you have to be very, very precise and very systematic in saying. You would do a general examination, you would do a
Yes, sir.
local examination, abdomen.
Yes, sir.
So don't combine, don't mix everything, right?
Sir, in general physical examination, I would like to know his performance status, his build, and his facial appearance, any lymphadenopathy, cervical, or pedal edema.
Yes. So general survey is a typical thing which is done in every patient. So go ahead with that. Just show us the general examination.
These are the points that I would be looking for in general examination, sir. Any abdominal distension, suprapubic bulge, any hernial orifices.
And the local examination?
Sir, in local examination, I would be doing a focused neurological examination in the form of perianal sensation, anal tone, and prepuce, meatus of the this meatal examination, whether meatus is stone nosed or it's of normal caliber. And
You told prepuce.
So
What
again,
you will look
I
for?
would just request you, when you just answer a question, be very systematic, right? When you're doing a
Yes.
local examination, just if you are seeing first the penis, go ahead with either there's phimosis, meatal stenosis,
Yes, sir.
any
Meatal
urinary
stenosis.
duration, anything, any lesion in the penis, and then you go ahead with testicles, looking at the testicles, scrotum, and then you go ahead with digital rectal examination, and then you along with do it a focused neurological examination. So you have to be very
Yes.
systematic in your answer, right?
Yes, sir.
Okay. So we have this on general and local examination. And one thing you said about the performance status. How would you see the performance status of the patient?
Sir, we have different performance scoring systems. We have Karnofsky's and ECOG performance scoring system.
Okay, fine.
So when would you call a patient disabled in both Karnofsky and in ECOG?
In Karnofsky, patient is called disabled when the Karnofsky score is less than 50%. He's not able to carry his work without support.
You have to be very specific. Less than 50 may be 0 also. So he's dead by that time.
It's less than 50, more than, sir. It's actually 180, 190, 80, 70. This decreased by
That
the
is fine, but you have to know exactly at what score the patient is
You are
called
supposed
disabled.
to know. Yes.
So it is 40 where the patient is disabled, and ECOG is 3 when it is disabled. Anyway.
So you are supposed to know it. Yes. No,
do you know
proceed.
any other scoring system besides these two? So this is Karnofsky and this is ECOG, right? 40 disabled and is this. Any other scoring system, like suppose if there is a child you are examining, does your scoring system change?
It does change, but I don't remember exactly.
It's the Lansky score. Lansky. And there are other scoring systems like Zubrod and WHO. But yes, these two are important, and the Lansky is important for pediatric patients, right?
Okay.
So how do you go ahead then? Performance status, ECOG is 0.
Right. So these are the findings of examination. The important findings which I want to highlight is that the right lobe had a hard nodular appearance and on palpation. However, the mucosa was mobile. So with these findings, I would like to ask if with these findings, what is the positive predictive value of abnormal DRE in case of carcinoma prostate? If you find something abnormality on DRE, so what is the positive predictive value?
Question?
Positive predictive value.
Positive predictive value of DRE for carcinoma prostate.
Right.
Sir, it increases up to
Probability,
80%.
right.
When a lesion is palpated on DRE, the positive predictive value increases to 80%.
80%. So in 80%, you are sure that this would be a carcinoma of prostate.
So finger is a very good screening method then, DRE, for every case. 80% is a very good score. You know?
Raised PSA on this.
No, we don't know about PSA at present. We are doing
Only
a
abnormal
What is
DRE.
DRE?
Digital rectal examination would be having a positive predictive value of 30 to 40% then only, if it's not combined with PSA.
Why did you say 80%? It is
Sir,
various
came
studies
about-
would say from 15-20% to
Yes,
40%.
30 to 40%.
Yes, 15 to 20 to 40%. So it is maybe 15-20 to 40. It depends upon the person who is doing. If it's a
Yes,
very
sir.
kind of experienced surgeon, then definitely the probability may be higher. Yes.
So, a differential diagnosis after your examination.
Does it change
Sir,
now?
It's a
What is your
60-year-old male.
in order you say of the differential diagnosis now?
Sir, my first diagnosis would be now CA prostate with bladder changes, obstructive bladder changes. Second would be, it's a young male, 60-year-old. I will not rule out prostatitis, chronic prostatitis. And
Chronic prostatitis was not your differential diagnosis to begin with, right?
Now, yeah, right.
No.
Why did you think of now? Sometimes the
Manzoor was
examiner they commit. You know, the examiner sometimes they commit something and distracts the examiner and the line of action. Now, you never thought of chronic prostatitis. Now you came because this is not a theory examination. This is dealing with a given case. Now you have uttered chronic prostatitis. Now see, you will get trapped. Now you will be taken another direction. What is the symptom or what are till now? What is there to suggest that patient might be having chronic prostatitis? Can you tell me any point thinking of chronic prostatitis in this case till now? Any marker?
he has obstructive
Don't
voiding
utter
symptoms.
what I am suggesting, don't utter irrelevant things in examination. It's a
Okay.
practical exam, so it's not a theory examination and you have to write something. Right? So there's
Manzoor-
nothing to utter here, chronic prostatitis. Right? Because there's nothing to suggest. At the
Manzoor, on
moment, yes.
digital rectal examination, if there is a hard nodular prostate, do you think some type of prostatitis could be could
Right.
show a nodular prostate?
I have studied it. Chronic prostatitis sometimes on DRE resembles, like you cannot differentiate it from malignant prostatic enlargement.
No, which chronic? It's not just a chronic prostate. It's usually a chronic prostatitis will be firm, small prostate, right? Maybe sometimes tender. That's all. But
So
which
now, yeah, Professor Shivam is trying to tell to save something about your thing because digital rectal examination is hard and nodular. Now, can you think of any prostatitis type? It's not chronic prostatitis. You have to now give a nomenclature to that to justify your answer, so that at least you are salvaged.
I'm trying to salvage you. That's all.
Chronic inflammatory prostatitis.
No, prostatitis is inflammation of the prostate. That's all. So, which type of can tuberculous prostatitis with calcification?
Yes, sir. Yes, sir. Yes, sir. Tuberculous prostate.
Can
The
some
granulomatous
prostate
prostate.
calculi be just be felt as a hard kind of surface?
Yes, if intraprostatic
Not
calculi are
very,
there,
very
they can.
usual. It's not very usual, but still, yes. Anyway,
So, what I would suggest when we should think of chronic prostatitis, just I would like to tell you, whenever you find this kind of clinical scenario and your further evaluation with PSA, MRI, everything is normal, and progressively you find the PSA is reducing and patient having a kind of a chronic problem with perineal pain for long term, not responding. So these are the area when you should, if only findings of a nodule hard and you should say that it is a chronic prostatitis, it should never utter. Right?
so the first thing that comes in the mind is a malignancy. That's right.
Yes, sir. CA prostate is the diagnosis.
Right.
Yeah, but at the same time, now the predictive value, as just now you have told, the probability is only 15 to 20%. So it could be something else also.
Something
So don't
else
forget
also,
it.
right? So that's why I asked him this.
Yes, sir.
So what next?
So which investigations do you want now?
Sir, in this patient, I would like to do a PSA of the patient. And routine follow, obviously, by using the same routine investigations, urine culture, CBC, RFT, and
So you should say all whatever you are basically
Whatever you
two types
want,
of
just
investigation.
I would like to start with the baseline investigation of CBC,
No, so
RFT.
just listen. There are two
Yes,
kinds of investigation for evaluating a patient. Once you find this kind of clinical scenario, one is focused investigation to reach towards diagnosis. And once you reach toward at your diagnosis, then all basic investigations for further management. So
Okay, sir.
first you come to the focused
So
examination.
Madhu, we are
investigation.
trying to now reach to the diagnosis, clinch the diagnosis. Now you
Okay.
have to
And you
investigate
should
this.
say
Right?
for each and every investigation, what is the reason behind doing this investigation?
Sir, I would like to get his PSA done.
Okay,
Only
one-
PSA, that's all. So you have
Sir,
only one thing in mind, that is malignancy,
No,
nothing
sir.
else.
PSA, urine culture, urine routine, urine culture, PSA, sir.
Okay. Okay. Anything else?
So-
No. So go. So just show us this urine routine culture and yes.
So these were the investigation baseline.
So what do you know? Are you wiser now?
Sir,
So it
PSA
is
is in the range of 14.41.
right. Right.
So this is a palpable nodule with a raised PSA. So now it's more hinting towards a malignancy.
Okay. Okay. So now the question comes, the previous question. If PSA is added to DRE, then what is the predictive value, PPV, of this?
Sir, it increases. Exactly, I don't remember what percentage.
All right. So to what extent you don't remember, right?
Sir, it's about 60.
So it will vary from 30 to 80%. Yes.
Yes, sir.
So in
So
various
it
studies,
ranges from 33 to 83% with PSA
Yes, sir.
level 3 to 15
More than 3.
or greater. So if it is up to 9, it's probably 30 to 40%. If it is more than 10, it is 50 to 80%. More than 20.
I think, yeah,
90.
just like here, I will just like to intervene. Now see, so much the moderator has put so much effort. And could you see what reference he has given? It's a very common. Now one cannot say that he had not read it. So this requires attention of all the residents to go through all these reference book. And everything is there available. So at least you can reply to these common questions. Maybe you may not be remembering 33 to 83, but at least you have an average. Yes, depending on serum PSA, this will vary around 30 to 80, as Professor Shivam has been telling you just now. So now this is the reference. Means now nothing is peculiar to you. Only that when you are dealing with a case and you are taking the round, you are going with the consultant, you are seeing the patient in OPD, you supply these things in your mind. All these questions have to be raised in your mind so that you go through the textbook and then you remember it. So that is the message I wanted to convey at this point of time. Right. Okay, further.
Manzoor, then go ahead. What do you think now is the differential diagnosis?
Sir,
anything else you would like to know? Which other investigation?
Sir, I would like to know his uroflowmetry, and also because with this PSA also still I have a BPH in mind, sir.
Okay.
So I would like to know uroflowmetry.
With a hard nodular prostate and PSA of 14, you still think it could be BPH, right?
Sir, remote possibility is there, but my first would be like it's a malignancy.
So again, you are coming to the. So now you are saying it's a remote possibility.
Manzoor, what is PSA density and how much is the PSA density in this particular patient?
Sir, I would like to know the prostatic volume. I don't remember exactly how much.
Okay. So if you have a prostatic volume, it may change your diagnosis. So
90 cc.
90 cc, right?
On ultrasound. On abdominal ultrasound, not part rectal, right?
So what is the PSA density in this particular patient? And what would be the expected upper limit of PSA in this particular individual? Okay, how much of PSA, what is what is the textbook figure of PSA density that you know of?
0.15, sir. 0.15.
But
Okay,
in this case, how much is the
0.16,
PSA density?
0.17. Okay. Okay.
So what it would be if it is 90 gram?
Sir, if it's 90 gram, 15 we will take.
Huh? 0.159 nanogram per ml, right?
Yes, sir.
Yes, you are
So
right. About a little less than 15.
Yes,
So
sir.
14.41,
Yes,
is
sir.
it acceptable or not acceptable?
Sir, it is acceptable.
Then
okay, so
you could have
what would-
substantiated BPH diagnosis, right?
So see, if the DRE would have been normal, didn't have show that a hard nodular prostate, then at least yes, then you would have thought in that direction.
BPH.
But still, you think that it could be BPH, and if you think it is BPH, which other investigation you would do here? Any role of free PSA as he's asking you?
Sir, definitely PSA derivatives will have a role here.
Okay, so you think with a hard nodular prostate, still you would do a free PSA?
Sir, this time, hard nodular PSA, hard nodular prostate plus PSA has made me more, towards this CA prostate is my number one diagnosis.
See, Manzoor, now we are asking you, you are a clinician. What would you
Yes,
do
sir.
next?
Questionnaire from the examiner is, do you think in this particular case, now see everywhere the money matters. Patient has to get
Yes, sir.
prick,
Yes,
again
sir.
prick. Another prick for getting anything done. It costs money. So now they're just asking you the rationale. Do you agree that this patient requires any free PSA or no? Have you any knowledge? So that is the role of the examiner.
Sir, no, sir.
When
There
to
is
get
no.
free PSA done? Are you
We
aware of?
don't do PSA in this range because this is clearly about 10, and we do PSA when we have a gray zone PSA 2 to 10 or 2 to 10 PSA.
So which other indices that you know of in gray zone that you would do?
Sir,
Besides,
we can do a prostatic health index, sir.
you know what it is?
Yes, sir. It's a 2 pro PSA, free PSA, and total PSA, and it is recommended by FDA by for now 2 to 10 PSA with negative DRA.
Don't try to be very precise. We didn't ask you whether this has been done by FDA or non-FDA.
Okay, sir.
So again, any other indices that you know of?
Sir, 4K score is the other indices.
Okay. So do you know what it is?
Yes, sir. It is, again, it's a total PSA, free PSA, intact PSA, and human kallikrein 2.
And
Okay.
Human kallikrein 2. These 4 things are taken.
There are 4 things, right? Free,
Yes,
total,
sir.
human
Total
kallikrein,
PSA, free PSA, intact PSA, and HK2.
Okay.
Yeah, so you must know all these indices because the examiner may ask you. Now we have
Yes,
only 12 minutes left for this case.
Right. So what do you think? You would go ahead with this in today's scenario when you have so many other investigations? Do you think in this case, what would you do? So this is the uroflowmetry of the patient.
So 12 was the Qmax, 300 was the voided volume, and 25 was the BVF. And this was the ultrasound findings. I'm telling you the findings. Upper tracts were normal. The bladder was more or less normal. The prostate was 90 cc. The PVR was 60 ml. The X-ray KUB was normal. So you should do a X-ray KUB in baseline when you are suspecting so many things. It's always better to have a X-ray KUB. It can give you so many information like spine, like bladder stone. So many information you can get with simple X-ray KUB with pelvis. So that is I think baseline you should not forget altogether. You should also keep this simple investigation in your mind. So what next? You will go for MRI biopsy or you will go for direct biopsy?
With a palpable nodule in the prostate and a raised PSA, I would like to go for a direct thrust-guided prostate biopsy.
So what are the things in favor of thrust-guided biopsy directly and not doing a multiparametric MRI? So anyway,
We
you
have
would
a-
try. Yes.
Yes,
Go
sir.
ahead.
We have a palpable lesion in the prostate. We don't need to, look for the. There is no history of any raised PSA and normal prostate is not there. We have a palpable abnormality in the prostate, which can be biopsied.
So how does your multiparametric MRI might help in this patient if you do it pre-biopsy. Do you know the guidelines? What does the guidelines say?
Yes, sir. Guideline says if this MP MRI is indicated when there is a raised PSA and DRE is normal and your previous biopsy is normal, and there
Okay,
is still
so-
persistent raised PSA.
Okay, so you don't think the guidelines say that it should be done prior to biopsy in such a patient?
Sir, it can be done through local
So this is
staging
what
of the.
is showing you the EAU guideline, which says that
Yes,
Manzoor, the
Yes, sir.
thing is that
Biopsy need.
MPMRI has two purposes. Number one, in helping you decide whether a biopsy is to be done or not. In this particular
sir.
situation, there is no doubt that biopsy
Yes, sir.
has to be done. So that
sir.
purpose will not be served by multiparametric MRI. The
Yes, sir.
other
So
thing
local
is
staging can-
that the other thing is local staging.
Yes,
And
sir.
if on rectal examination, you have to find out how many nodules are there, whether the
Okay.
patient would still be a candidate for a curative therapy in the form of radical prostatectomy or not. If the patient is likely to be a candidate for radical prostatectomy, then MP MRI should be done before. Because if it
Okay.
is done later on, then there would be a lot of artifacts that will come because of the biopsy. They're going to take 12 or maybe 14 pores in this particular individual. And there will be so many artifacts that may come up. So in that situation, MP MRI as a staging procedure should be done before.
Okay. sir.
one thing I think here should be added that Manzoor, how many times
sir.
you get a negative biopsy also?
Sorry, sir.
If you are doing just a trust-guided systemic biopsy.
Yes, sir.
Have you heard of negative biopsies in these patients?
Yes,
Even
sir. We
with
have
a
heard.
raised PSA?
Yes, sir. We have heard.
What is the drawback of doing a direct trust-guided biopsy, systemic biopsy? And what is the advantage of doing an MRI before?
Yes.
False negative rate is
That
high
is
in
correct.
case of doing a trust guided or guided trust guided biopsies, whereas the detection of the high.
Yes, it is there. Yes. Yes.
Sorry, sir.
Yes. Man, it is
Yes.
there. You can get a negative biopsy
Yes, sir.
even if the patient is harboring the CA prostate.
And
So how do you-
yes, sir. We can get a MRI guided biopsy that will actually detect more high grade lesions and.
How would it help? How? Which type
clinically
of biopsy
significant.
you will take?
So trust guided, MRI guided, MR fusion trust fusion biopsies, MR trust fusion biopsies.
So how is it different from your trust guided biopsy?
Sir, it actually, we take normal trust scores also, and we record, we record the pre-biopsies, lesions are recorded on MRI picture. They are
So what
taken
is that
separately
called?
from the.
What is that term called when you do take some biopsies, when you have that on the lesion guided biopsy? What is that term called?
Yes.
What is cognitive fusion biopsy?
Yes, sir, cognitive fusion biopsy. This
No,
is
no.
cognitive, is like, this is fusion,
See,
MRI fusion biopsy.
MR fusion could be cognitive, non-cognitive. That is fine.
Yes, sir.
But
Yes, sir.
what type of biopsy it is, Chirag? When you see on a MRI and then you take it on ultrasound,
Guided biopsy, sir.
it's a targeted biopsy.
Yes, sir, targeted, sir. Targeted.
Targeted. Well, you can
Yes.
take a targeted biopsy plus a systemic biopsy.
Yes, sir.
And
Yes, sir.
if you combine the two, definitely the results would be better.
It will be more better.
The outcome of getting a malignancy would be better, right?
Yes, sir.
So that is another advantage of doing a multiparametric MRI before biopsy. Okay, so let's go ahead. If we have done a multiparametric MRI, go ahead with multiparametric.
So now, sir, it's a chance for Dr. Vivek to come in. So, Dr. Vivek, put your audiovisual on.
Good evening, sir.
Yeah, you can
Good.
continue
Yeah.
now.
That's good.
Good evening.
Maybe.
Good evening. So go ahead, Mukesh. So we have a multiparametric MRI here. You can show all the other films also. So these are the films. What do you think?
T1 weighted.
Yes, sir. This is MPMRI showing you hyper intense lesion in right lateral lobe of prostate.
This is a which one? This is T1 sequence, T2 sequence.
So in
Sir, this is
multiparametric,
T1, sir,
component.
sir, this is T1 sequence.
T1.
Sir, yes, sir.
How do you differentiate between T1 and T2?
Sir, because water is white in T2 image, and as we can see the bladder, the inside
Right. Okay. Proceed.
urine inside the bladder is appears as dark, so it is most likely T1 image.
So which are the components for a multiparametric MRI? How do
Sir,
you? Yeah.
sir, T1 T2 image होती है, sir, T2 image and diffusion weighted image and dynamic contrast enhanced image.
Okay. So which version we are using?
Sir, currently we are using, sir, 1.5 Tesla or 1.5 Tesla to currently the MRI available in India is 1.5 Tesla to 3 Tesla.
Which pirate scoring version?
Okay, sir. Sir,
Anyway, do you know the full form of pirate?
sir, prostate imaging and reporting data system.
Okay. So besides this multiparametric MRI, do you know any other kind of MRI which is used in CA prostate? Nowadays, we are doing a study with other kind of MRI also. Have you heard of biparametric?
Sir, yes, biparametric, I heard it.
So what is the difference between biparametric and multiparametric?
Which
Sir,
one
I
is not there? So in biparametric, there are two components,
Sir,
right?
two components.
Which one?
Sir, diffusion weighted image is diffusion weighted is not in biparametric.
Huh? My God.
Sir,
So no, haven't studied.
okay, sir. Sir, actually, I don't know biparametric.
Ah, right. So do you know that which component has which dominant technique? Means the T2 weighted image is measured for which zone of the prostate, and diffusion weighted is measured for which zone of the prostate. Any idea?
Sir, T2 weighted image is for prostatic anatomy in prostatic anatomy and surrounding prostatic anatomy is better visualized in T2 weighted image, and while other soft tissue structures and peripheral anatomy is better visualized in diffusion weighted image.
You have to be very precise, right? Diffusion weighted is for peripheral zone and T2 weighted is for transition zone, right?
Okay.
And that is why these two things are very important. These cannot be excluded, right? The other thing, which is enhancement, contrast enhancement, is not there in biparametric, right?
Yes, sir.
Yes.
So how which one is better in biparametric or multiparametric? The whatever literature I found, as per the literature and my understanding, when the biparametric MRI is more than 3 or is equal to 4, the multiparametric MRI help diffusion weight, but the dynamic contrast MRI helps for diagnose the clinically significant malignancy. So as of now, probably multiparametric MRI is better ahead of biparametric MRI, but we need further evidence.
Usually what happens that if the diffusion weighted is equivocal in case of biparametric, then the contrast enhancement, if positive, then the pirate score would go to 4. So that is the usual, when it becomes equivocal, then it becomes more important. Then if there is contrast enhancement, then it will be pirate 4 rather than 3. Yes.
Okay, sir.
So this was the findings of MP-MRI. What is the probable pirate score?
So now go ahead.
So this was the pirate scoring.
Sir, pirates most likely, sir, pirates 5 score, pirates 5 in this.
So,
Okay,
so
so
what do you
kind
mean
of
by pirate 5? What does
right.
it mean?
Sir, I would like to do trust
So
guided
which-
biopsy.
Sir asked first question, what is pirate 5?
Sir, pirates 5 is a confirmed confirmed malignancy.
Okay, so the
That
chance
is-
of malignancy is almost 100%, right? In this
Haan,
stage.
sir.
Here. Yes.
Yes, sir.
Fine. So not what type of biopsy would you like to do in this patient?
sir, transrectal ultrasound guided biopsy, trust biopsy of prostate.
Again,
We can,
so
sir,
we would take a targeted plus a systemic biopsy, right?
yes, sir, targeted and plus systemic.
You have already a MRI, so you would do a MRI fusion biopsy. It could be cognitive, it could be even with the MRI fusion, with the,
Yes,
right?
sir.
Yes.
Yes, sir.
Okay. So you would take a targeted plus systemic biopsy. So the next question is what information you would look for in a histopathology, in a biopsy? What are the
Sir, yes, sir.
things
Sir.
that you
Yes,
Go
sir.
ahead.
First, I would, sir. First, I would like to know Gleason's score in biopsy, and then I would like to know which type of carcinoma, whether it is adenocarcinoma, which in biopsy. And then I want to know how many cores present in biopsy report, and then how much maximum core involvement in biopsy, and a peripheral neural invasion. I want to know peripheral neural invasion and lymphovascular invasion.
So number of core, percentage of core, right?
Yes.
Hi, sir.
Number of cores positive.
And percentage of cores.
How does percentage will going to change your management?
Sir, actually, according to EUA risk stratification.
How does it change? Is there any risk stratification where the risk stratification would change?
Sir, yes, risk stratification, DMEGO risk stratification criteria, and EAU risk stratification criteria. And
No. See, we are asking you how would it change? So do you know how can the risk stratification criteria change with the percentage of involvement?
No, sir. Percentage by percentage it will not change, sir.
So
Okay,
why you
so
need this information?
So do you know there is a very low grade and there is a low grade stratification, low risk stratification, very low risk? How does it differ? Any idea?
Sir, there is low risk,
very
intermediate risk.
Low risk.
Sir, there is low risk, intermediate risk, and high risk criteria.
No. You don't know of very low risk and very high risk, yes? No idea. Okay. Let's go ahead then. Yes.
So this was the prostate biopsy findings.
So one is ISO grade. What is this ISO grade for?
Sir,
Group
this is Indian. This is International Society of Uropathological Grading.
Right. So you didn't tell us about the group also, right? Which is again important, yes?
So if it is 3 plus 4 and 4 plus 3, what is the difference between these?
How does it differ?
Sir, the 4 plus 3 is more severe than 3 plus 4.
No, the group grade will change or group grade will remain same.
Sir, no, it's a group. Sir,
So
group
3
grade
plus
will be.
4 is which group and 4 plus 3 is which group?
Sir, group grade will be changed, sir. The 4 plus.
Okay.
Sir, 4 plus 3 is 1 grade higher than 3 plus 4.
Yes.
4 plus 3 is 1 grade higher than 3 plus 4.
Which grade? Grade 1, 2, 3, 4?
Sir, actually 4 plus 3 is grade 4 and 3 plus 4 is grade 3.
Okay.
Okay, group 3 and group 4. Fine.
Group 3 and group 4.
So what next now? So you have this biopsy report. What next you do? Any other investigation you want to complete? So still you want to know what?
Sir,
so which risk group it is now? Which risk group it is?
Sir, it is high risk group.
Okay, so in high risk group, what else you want to know?
Sir, I want to know the further PET scan or bone scan.
No, you want to know the metastatic. You want to do a
metastatic workup. I want to go for metastatic.
You think you would do a PET CT or a bone scan?
Sir, in this patient, I will prefer PET CT, sir.
Okay, so routinely you are doing a PET CT for
Sir, no, sir.
metastatic.
Sir, no, sir. If a patient have any symptom of bone pain, or if PSA is more than 50 or more than 100, then we will prefer bone scan. But at this PSA, bone scan is less sensitive, so I will prefer PET scan to.
So this is
Can
your
there
practice.
be visceral metastasis without bone metastasis? Can there be visceral metastasis without bone metastasis?
Sir, usually, sir, bone mets occur first in patient, but in literature there are reports that visceral mets can occur without bone mets.
Will the lymph node metastasis will picked up by bone scan?
So would you like to know the lymph node status or not?
Sir, yes, lymph node. I want to know the lymph node status
So
also.
you didn't tell us about that.
Sir,
Okay, so how would you know the lymph node status plus all the metastasis, right?
Yes, sir.
You already got a MRI, right? MRI pelvis, and there was no lymph node.
Yes, sir.
So, do you think that there will be a possibility of a non-regional metastasis without a pelvic lymph node metastasis?
Is it possible?
What is the chance? Yes.
Sir, yes, sir. It can be possible that there may be.
Okay, okay. So you think this? You would do a PSMA PET CT, right? This is PSMA PET, right? Okay.
Yes, sir.
So it is your practice, or it is on basis of evidence? Because the cost of bone scan, PSMA PET scan is differ, the availability is different.
Sir, it is a practice. Actually, it is not included in guideline yet. PSMA PET scan, but it is currently practicing.
Okay. Okay.
So it
why
is being
not in the guidelines? Because why? Why do you think it is not in the guidelines?
Sir, because it is a newer study, and yet studies.
Right. So we do not have a long-term study to know the exact outcome. Fine.
Yes, sir.
So as per NCCN guidelines, you should do a cross-sectional imaging and bone imaging in a localized prostate cancer, right? Clinically localized. As of now, the guidelines is this.
Yes, sir.
Right.
So PSMA can probably is more accurate for staging than CT or bone scan, but today no outcome data exists to inform subsequent management. So lack of data to recommend PSMA PET scan for metastatic evaluation in prostate cancer in localized prostate cancer. Right?
Yes, sir.
So we have done this, right? So this is the bone scan that we have, a normal scan.
So, sir,
What do you think
we
now
need
that your
to.
diagnosis?
Sir,
What
we
is
need
your
to
diagnosis?
wind up.
Quick.
So we need to wind
Yeah,
up.
we
this
have to be
case,
quick. Yes.
Yeah, need to wind up this case.
Yes, sir.
So
Sir, my
what is
final
your
diagnosis is.
Go ahead.
Sir, my final diagnosis is clinically localized
So
high
it
risk
is
CA prostate.
T2, yes, T2B and 0M0. Fine. So what
Yes,
would you do? Go ahead.
Sir, I would prefer a radical prostatectomy in this patient.
So only you will counsel.
Sir,
You should always counsel the
many other
patient, right?
treatment options are there, like active server. I can I can.
So which other option you have in a high risk localized CA prostate? 60-year-old with a good
radical first option is ready. First option is radical prostatectomy. Second is radiotherapy.
Do you know a special type of radiotherapy? Which side of radiotherapy?
Sir,
Which type of radiotherapy?
Sir, इसमें sir high intensity.
You have to be very clear about this.
External beam radiotherapy. In this prostate, I will prefer external beam radiotherapy.
So
and
but there are modalities.
Hypofractionation radiotherapy. Hypofractionation radiotherapy.
You have to be very, very precise in your answer. 3D conformal radiotherapy with IMRT, IDRT, everything that you have, whether you add brachytherapy or not, right?
Sir,
I will. Study, there is meta-analysis which would tell you that they have almost the same results. If you go to a radiotherapist, they will say they will prefer first as radiotherapy the option. So don't say that this is the only option, right? So you have both the options with you. Anyway, so what else? So if you do a radical surgery, which kind of radical surgery? Which approach?
Sir, it is a large prostate. So I will prefer a suprapubic radical prostatectomy with a
See, you have
extended pelvic lymph node
which is like
dissection.
open lap robotic. Which would you prefer?
Sir, I would prefer robotic.
So what is the advantage? What is the advantage of robotic over others?
Sir, because if minimal invasive, it is minimal invasive procedure and with less hospitalization.
See, lap is also minimally invasive. Any advantage of robotic over lap?
Sir, robotic. Sir, actually, lap is robotic is more comfortable to the surgeon, and lap is very cumbersome when we do robotic lap radical prostatectomy.
The important
I think,
thing
yeah.
concerned is about the oncological outcome, the incontinence and erectile function. Does it change? Does it change?
Actually, yeah. When we deal with any case, I think discussion can go for hours. But only that, yes, I am just listening to the instruction and suggestion and advice from the secretary, Dr. Anup, that we have to wind it up. Now what is situation here? You should know all these things, and the knowledge can be now only one. See now, what the examiner was attentive to. I have just heard you told suprapubic prostatectomy. I have heard of it. I have not overheard it. Now, what is the type of radical prostatectomy you call it? Whatever, laparoscopic or maybe open or maybe robotic. So now I heard only that one point by the examiner, because by the examinee, and then I am just coming on that. What is the exact prostatectomy called for radical prostatectomy? What is that exact term? Okay, so now what I'm trying to say, be careful whenever you are talking, and then the case is very obvious. Again, you uttered, I think, watchful waiting and against active surveillance. I think this case doesn't, again, nobody will utter. So now I am just making you examining careful. Please don't utter such things. Now we are not asking theory until somebody asking what are the options for CA prostate, then you answer. But in this case, that is not an option. So now I could hear you uttered quickly, but you just have withdrawn immediately. But better don't utter because you are dealing with a case. Right? So I think maybe that we can bind it up with Dr. Anup, because time doesn't permit. There is a discussion, otherwise quickly within another 3 and 4 minutes we can cover whatever points Dr.
Surekha, you can wind up now.
Yes. Yeah. Right.
Right.
So you can go quickly now. How to follow up these patients, following this, how long to give a DT. These are the query you should have, and then again try to understand and have conception about that. Yes.
Okay. So Vivek, just tell me one thing, that what points in histopathology will make you refer this patient for early radiotherapy?
That's right.
Sir, if there is perinural invasion or lymphovascular invasion present, then or sir, if there is margins are positive, and
is perineural invasion an important prognostic factor? Perineural invasion has not been found to be an important prognostic factor.
Lymphovascular invasion.
The margin positivity, that is
margin positivity. Okay, sir.
Margin positivity, and if in the post-operative 4 weeks PSA, the PSA is more than 0.5. Okay, margin positivity, but this is already Gleason's 8, 4 plus 4.
Yes.
So it is already a high-grade disease. In high-grade disease, if the margins are positive and if the PSA does not settle to less than 0.5 at 4 weeks, then these would be indicated for immediate radiotherapy. Okay. And then you can talk about immediate radiotherapy versus salvage. So those issues are different, but this is an important issue to be settled at the post-op time. Let's go to the next one.
Okay, so
Thank you, sir.
thank you, Dr. Surekha, for wonderful case moderation, and thank you
Thank
all
you,
the
sir. Thank you so
postgraduates.
much.
Thank you all postgraduates for taking up the viva and facing the questions from our esteemed teachers. Now the case second will be moderated by Dr. Sudhir Divana, and the first student will be Dr. Gaurav. So please put your audio visual on.
Yes, sir.
And,
Good afternoon. Good evening, sir.
Dr. Sudhir, you can start the case.
Good evening, everyone. At the outset, I want to thank NZUSI and Dr. Anoop for giving me an opportunity to be a part of this educative event. So without wasting much time, I'm going to the second case. So I'll be asking first the questions related, first starting with Dr. Gaurav. So Dr. Gaurav, am I audible?
Yes, sir. Good evening, sir.
Yeah. So you are sitting in an OPD, and here is a 26-year-old male who is a resident of Ropar from Punjab. He came to you saying a history of road traffic accident on 25th of February this year, and the mode of accident is by run over by a tractor. So he had, since that time, he had inability to pass urine. So what further history you want to ask from based on this?
Yes,
Go
sir.
ahead.
So,
Yeah, please do, yes.
so I also want to know about if he's having any blood meatus, and is he having any pelvic fracture, unable to move after this injury, or and what are the vitals of the patient, and is the bladder
No,
palpable?
actually, I think just now again moderate. I think I should give it. Now this point of time. Now see, can you see the second line sentence? Inability to pass urine since then means today is 23rd May, and he had this history available to you. He had roadside accident, and then he has been not passing urine per urethra since then. Now, what are the relevant history would you like to know? Whether there was blood at meatus or not, whether RG was done or not? Is it that?
Yes, sir. Yes. Okay, sir.
So
I
go
got it,
ahead
sir.
with and ask whatever you want. So
Sir,
you think?
at that time, yes, sir.
Go ahead. Go ahead.
So at that time, was there any blood at meatus? Second thing, was there any pelvic fracture or any associated abdominal or
Right.
any other
Yeah.
injury? And
Yes.
was the patient tried for the catheterization or SPC was inserted?
Okay.
Or
Okay.
was there any imaging, cross-sectional imaging, or any retrograde ureterogram was done at that time, sir?
Okay.
Okay. Okay. So let's see what was done.
Just a second. So, so always I will show the patient details anyway. So you need to ask about the detailed history related to the road traffic accident at that point of time.
Okay.
Yes, you already asked the blood meatus and contrast. These questions you have anyway asked now. So let us.
So the important thing here is that when the patient comes to the road traffic accident, it is not just a urethral injury, right? Or
Yes,
a
sir.
fracture pelvis. There may be so many other associated injuries. So you need to ask the patient, he might have a head injury, he might have an abdominal injury, he might have rectal injury, so many. So you have to be very clear that there may be so many other associated injuries.
Yes, sir.
Right?
Yes, sir.
So
Right,
in the
sir.
So
history,
detailed,
you ask
yeah, injury, right?
detailed history.
So you should cover each and every history like what sir has told: head injury, any bony injuries related to pelvis, long bones, abdominal organs, bladder injury, and even rectal injury, which are very important. Sometimes by the time patient reaches you by this point of time, he might be on a colostomy also. We don't know. Because of
Yes,
the
sir.
rectal injury, they might have done diversion also. So obviously all such injuries you need to take history related, that whether there is any such type of injury. And then any orthopedic surgical intervention or any abdominal surgical intervention you should ask. And then definitely sometimes even an endoscopic procedure also they might have undergone. That history you haven't asked. That also we should ask. Okay.
Yes, sir. Right, sir. Yes,
So
sir.
Again,
this
the
patient,
2 months have passed. Now, any other thing that you want in the history? Do you want to know anything else?
Sir,
Suppose there was a rectal injury associated. What kind of symptoms the patient would present? Which probably has been missed. and there was nothing done for that.
Sir, the patient may have developed a fistula.
Right. So how would the patient
rectal-
complain?
Sir, the patient may present with a fecoluria, sir.
More common is?
No. See, now actually the fecoluria patient is not voiding, right? So now just I think now we are just trying to focus.
Yes.
So you would like to know that what are the injuries patient these have, and you are making the question accordingly, right? And now when you are telling patient has fecoluria, is it voiding? You are putting a question on the presentation.
Yes.
Hello.
So, anyway.
Yeah.
Yes, sir.
So is there a possibility that even after a urethral injury, the patient may pass a few drops of urine?
Yeah. Yes, sir. It is possible, sir.
Yes. In which cases? And that is why this is no more called as PFUDD, but there's some other term used. What is that
yes,
term?
sir. Sir, pelvic fracture urethral injury, sir.
Right. So which cases?
Sir, I'm sorry, sir.
Okay. So we will go
Now,
ahead with that. Ask you
so
again.
type of pelvic fracture and injuries has been described. You must read it. That actually the urethral injury, the type, you must know it. So that's why
And
that is the question.
Which other important history that you want to take when there is a urethral injury? There may be injury to some other areas which will lead to his symptoms.
Is he
right?
having any erectile dysfunction, sir?
Yes. So sexual dysfunction, erectile dysfunction you would ask for, right?
Yes, sir.
So why does the erectile dysfunction occur in these patients?
Sir, in case of pelvic fracture urethral injury, sir, there are associated vascular and neurological injury that's why it may cause erectile dysfunction, sir.
Yes.
Okay.
There could be any other reason other than vascular and neurogenic? Is there any other reason for causing erectile
Any other
dysfunction?
cause in such a devastated patient where there's a
psychological, sir?
Yes.
Post-traumatic psychological.
Yes. Stress and stress related.
So coming to the present case, yes, he had blood meatus, and at that time, no imaging like RG was done at the time of injury. Straightforward, they have attempted a periurethral catheter, but of course it didn't drain urine, and subsequently they have placed a suprapubic catheter. There are no other associated injuries which we have discussed. Now the patient is on SPHC since 3 months. Of course, sir has anyway asked the question of what else you want to ask. So if you go to that, the relevant history which you need to ask is like, sometimes if you have an incomplete urethral injury, the patient might pass urine as well. Of course, this patient is not passing because he's on an SPC. So you should anyway ask that history, because sometimes whenever the SPC gets blocked or anything, patients do say that they pass urine few drops through the urethra. So that you should ask, that says that there is a continuity is there, still there to the bladder. The other thing is, yes, bowel habitus you should always ask, because if there is associated rectal injury, yes, you can have sometimes the patient say that when the catheter gets blocked, some of the urine might leak through the anus also. Any fecal incontinence, this is very important, which you should always ask, because if there is full thickness rectal injury, patient might have incontinence as well, fecal incontinence.
So I would ask him here, would you do a RGO in the emergency or not?
Yeah, he's asking during trauma.
So after trauma, if the patient comes to emergency, would you do a RGO or not?
Sir, during trauma, if the patient vitals are stable, then yes, we can do an early retrograde urethrogram, sir.
All right. So stability. So that the patient is stable, then yes, you can do. So what type? How does it differ from your normal conventional RGU?
Sir, usually the immediate post trauma, the patient is not shifted to the radiology unit, but it's done under the CRM only, in the emergency room only, sir.
No, but the technique.
He's telling the method applied. Do you think it is different from other conventional RGU which you are doing? Something can you remember in cases of trauma?
Sir, in normal retrograde urethrogram, we have to tilt the patient to the lateral position. But in this case, as we normally suspect a pelvic fracture, so we can't just shift the patient into the lateral position. So we have to do it in supine position, sir.
But what is the
Anything
more
else?
important thing that we are trying to ask you is how would you push the contrast? Because this is an injured patient.
Sir,
And
yes, sir. I got it,
yes,
sir. Sir, we should never push the contrast. It should be always under gravity, sir.
yes. So it should be a gravity agent. Fine. Go ahead.
Yes.
Go ahead, Sudhir.
Yeah. Like you have already said that you will ask history for erectile dysfunction. So history of nocturnal erections, those things you should ask. Then surgical history, we already discussed that any procedure being done that you should say. And definitely in personal history, any treatment he had received in the past regarding this, and what is his marital status, and then the comorbidities. So
Yes.
those things you should definitely ask. So in this case, he says that he doesn't pass any drops of urine through the meatus. There are no other symptoms, and he is having normal erections, and his IEF score was 21. And of course, I already said that he had no addictions, and he's married and having one child.
Yes, sir.
So based on this history so far, what differential diagnosis you want to put right now?
So there was no any history of fracture, right, sir?
Yes, on history, yes,
Yes,
there
sir.
is fracture is there.
There is fracture pelvis.
There is fracture.
Sir, it is a case of pelvic fracture urethral injury, sir.
Right.
My provisional diagnosis is this only, sir.
So he's asking you differential diagnosis.
No, sir. Sorry, sir.
Any other?
There is no differential diagnosis?
No, sir. No, sir.
Can there be a possibility of other than pelvic fracture injury? Is there any possibility of other associated urethral disease like stricture or anything in this case? Can it be possible?
So it can be possible, sir.
You can sometimes have both, because he has an attempted catheterization at that point of time.
Yes, sir.
Yeah. Okay.
Yeah.
Yes, of course, the history is straightforward in this case. It is a clear-cut case of pelvic fracture urethral injury. He might have any other associated injuries as well. Okay.
We must do a physical examination also, right? So see,
Yes,
suppose the patient had a phimosis, a dense phimosis, right? So that was missed, and they did a suprapubic cystostomy.
Yes,
Can you think of that case that the patient is not able to pass urine because of the closed meatus or the closed prepuce,
yes,
and
sir.
that was missed on emergency?
Yes, sir. Possible, sir.
So again, so you don't have to be very biased about your diagnosis, right? So examination is a very important part still.
Yes, sir.
What you want to examine?
What would you examine?
So first, in general examination, I would like to know about any pala, icterus, or vitals of the patient. Any
Local examination?
In local examination, I want to check the external urethral meatus, the status of the penis and bilateral testes and scrotum, any previous scar, the site of the SPC, whether it is central or lateral, and how much it is above the pubic symphysis. And I also want to do a digital rectal examination.
Okay.
What information you would like to obtain from DRE?
Yes, sir. Sir, the prostate may be found high prostate may be found. That may indicate there is a larger gap, urethral injury defect, sir.
So after 3 months, you will get a high riding prostate.
So normally it should not have been found, sir.
So you only told us.
Sorry, sir.
So you're examining it after 3 months, right? So what happens to the high riding prostate, and why it is due to?
Sir, it is due to the hematoma formed
Right.
due to the injury.
What happens to the hematoma
So
after 3 months?
with time it resolves and the prostate comes down, sir.
Okay. So you may not find a high riding prostate after 3 months, right? Even if
Yes,
there was a big hematoma. Yes. Go ahead. Anything else?
So I think, sir, we can now include the second candidate, Dr. Gaurav.
Right.
Is now Dr. Sunil can join.
Thank you, sir.
You can
Okay,
put your
Dr.
audio visual on.
Good evening, sir.
Yes. Good evening. So you go ahead with the patient has been examined already.
Yes,
and
sir.
what else now you want to know now? So we have general examination, which is normal, and
Yes,
a
sir.
local examination done. Show him the local
Next.
examination.
One important thing in general examination, which I want to add, sir, in particularly in pelvic fracture patients, because depending upon the severity of pelvic fractures, sometimes these patients, they have difficulty in walking also. Even they are unable to squat also. That is important when you're planning surgery. So what is very important, good habit to examine their gait, and at the same time whether they are able to squat and get up. So that is one thing which is important in general examination. Of course, the rest of the things he has clearly covered, the SPC, whether it is in the midline or not, and then the examination findings. In this case, there is no phimosis, meatus is normally located, and there is no spongiofibrosis in the urethra, and testes or everything are normal. And the perineum also always very important to look for any scars. Then on DRE, he said that he will be looking for a high riding prostate. Of course, there is nothing is there in this case. Most important thing is the anal tone, which is very important when there is an associated rectal injury or the perineal injury. So you should always look for that. And definitely on DRE, you should look for the rectal mucosa, how it is, and whether there is any bony protrusion, which is sometimes you feel those things when you are doing DRE. So these things are very important, which you should never miss.
So
So this is
Gaurav,
just a,
yes. So
sir,
Gaurav,
this
he
slide
told
I
about the anal tone and also told about the squatting, right? He is not able to, whether he is able to squat or whether it is the gait. Why it is important, the gait and squatting?
Sir, because as we have to do any surgical procedure in this patient, and most probably progressive perineal urethroplasty, and in that the lithotomy position will be required, sir.
So lithotomy position, whether he is able to, yes. Anyway,
Yes.
what about anal tone? Anal
So
tone,
Dr. Sunil can take over now as a candidate. Dr. Sunil, you
Dr.
take over.
Sunil, are you ready?
Yes, sir.
Yes,
Sir,
Sunil.
we will. Sir, we will get
The
the
anal
anal
tone is important here.
tone to rule out any rectal injury also, and to rule out any associated sacral nerve injuries, neurological injury.
All right. So neurological, even these cases which have pelvic fracture, they can have sacral nerve plexus injury and can
Yes,
cause
sir.
neurogenic bladder. So the
Yes.
results would be, yes, very important, right? So you have to rule
Yes.
out neurogenic element also. Go ahead.
This is just another case, not this case, sorry. I just kept it for examination of the perineum is very important. And then at this point of time, what investigations you want to ask?
So Sunil, your investigation, yes.
Yes. Sir, I will like to do routine blood investigations like CBC, RFT, sir, and urine routine and culture sensitivity, sir. And
Sunil, you have been told so many times that the investigations are of two types. One is to clinch the diagnosis, other is for your pre-op investigations. So when we are asking you in a patient who we need to clinch the diagnosis, so we need to investigate in that direction, right? So in that direction, what investigation you want?
Sir, MCU with RGU, sir.
Okay. So he wants an MCU. MCU and?
RGU, sir.
Prior to that, you want to do any culture or not?
Yes, sir. Urine culture sensitivities.
All right. Is it important before doing RGU?
Yes, sir. Otherwise, patient may go into sepsis.
So even if you have, suppose a patient with SPC, the culture may be positive. Then?
Sir, then we can do MCU-RGU under antibiotic cover after giving antibiotics for 48 hours.
Under antibiotic coverage. And if the patient doesn't have any features of sepsis, right?
Yes.
Okay. So this was the urine culture, and this was the routine test that we did. So what do you want to do now?
Yeah.
So you said RGU MCU. What do you want to know from RGU?
Sir, first on the scout film, sir, I would like to see what are the injuries present in the bone and have they healed, or what is the dissection defective present in the pubic bone, or if any fracture is present, where it is present, and if any plate applied by the ortho team, if it will not come in my field, sir, if I will plan for operate this patient, sir. And then I will see also for any vesical calculus if present, sir, in this patient. And in then MCU and RG film, sir, I would like to see the where is defect is present and what is the size of the defect and what is the yes, sir,
Any other associated besides the defect? So you may not find a defect at all. So you are saying you would get a defect. If you don't get a defect, then?
No, sir, I would see if any defect is present, sir. I'm not
right. So there may be or may not be. Fine.
Yes.
So what else besides the urethra? What else you would like to know? Besides the defect,
sir, sir, bladder contour and bladder neck, if it is opening or not, sir. Sir.
Right. Right. And
any
the proximal urethra and the bladder? Yes. Fine.
Yes.
Anything else besides the defect? Would you like to know the anterior urethra also?
Yes, sir. In RG,
normal or not?
Yes, sir. Both anterior and posterior urethra, sir. I would like to see the status.
Right. So let's go ahead. Yes.
So, I think many points you have already covered. Like you should look for any other radio opaque shadows in the plain X-ray film. Yes. Also evaluate the bony injuries, tiles classification, which you should know, and then the length and alignment of the urethral defect. So you need to see whether how long the defect is, whether both the ends are aligned properly or not, or in line or they are deviated, and then the status of the bladder neck, which is very important. And this point which you have not covered, is there any leak? Sometimes you might have an occult fistula, because we are thinking that there is no rectal injury in this case based on the examination and everything, but always you should have a thought of this also, because sometimes minimal leak you can miss. So that you should always look for. Most important thing is the post evacuation film. After you do RGMCU, after you empty the entire contrast, you should again take a film to see whether there is any retained contrast anywhere. So sometimes if you have a rectal injury, the contrast might have gone there, which you miss in the initial films, but after evacuation, that is the only contrast which will be there at that point of time. So this is very important. So this is the RGMC film of the given patient. Now you can read the film now and tell us the findings. Oh, sorry, I didn't keep the plain film. I don't have it. So these are the main films which I have kept.
Sunil, it is very important. You have to ask for a plain film also, right?
Outfit, yes. Yes.
Yes. Yes. Go ahead.
The points which you have told, you can look for those points in this case.
In first RGU film, there is fracture on inferior pubic rami on both sides, and rest all bone appears to be normal, sir.
So not on superior pubic rami.
You don't see any fracture of superior pubic rami or not?
On the left side?
The left side there is doubt, sir.
So you missed it, right?
You can see in the second film also it is visible.
Yes, sir. And second film it's clearly visible. Yes, there is.
Right?
Yes.
So which type of injury?
Actually, it is a butterfly. It's a complete butterfly fracture. You can see both superior rami as well as inferior rami.
Right. So which type of bony injury it is? Do you know of any classification?
So there is tiles classification, but I don't remember exactly.
Tiles classification. Basic principle of the type step. There are 3 types, right? A, B, C. So a basic principle of classifying fracture pelvis.
So anterior posterior compression and
that is the type of trauma. That is the impact of trauma, right? Anterior posterior or exterior. So, but in fracture pelvis, how would you classify? The basic principle is
ABC.
Open book or
no. First of all, you have to see whether this is a displaced or non-displaced kind of fracture, whether there is any rotational or vertical displacement or not, right?
Yes.
So vertical displacement is usually if there is a sacral injury, iliac injury, iliac bone injury. Rotational is, as Dr. Amnish said, it's a kind of open book kind of fracture where both the pubic rami get fractured, or there may be a symphysial diastasis, right?
Yes. Yes.
Type 1 is a non-displaced kind of type B would be a kind where there is only vertical displacement, and type 3 is when both, right?
Yes.
So, yes. So this is type B, right?
Yes, sir. In this vertical displacement is there.
So there's no iliac or sacral, you can't see probably, at least from here. Anyway.
Anterior posterior. Yes.
So go ahead.
Sir,
Anything you want to know?
on RGU, penile and bulbar, up to mid bulbar urethra, it appears to be normal, sir. There is no narrowing seam contrast. Urethra is well delineated, sir. On MCU film, sir,
Just stop here. Stop here. So you said mid bulbar. Show me the proximal bulbar. Where is the proximal bulb here?
Sir, when a line joining the superior border of inferior pubic rami is joined, that usually correspond to bulbomembranous junctions.
So you think this is the line joining doesn't cross this? It's much below that.
So I think so.
What do you expect in this patient of a fracture pelvis urethral injury? Where do you expect the injury to be?
The bulbomembranous junction is most common site.
So bulbomembranous junction, right?
Yes. Yes.
So it's not in the bulb, right? It's a bulbomembranous. So which type of injury will have a kind of bulbar injury only?
So straddle injuries causes bulbar injuries.
Perineal trauma, right? Due to straddle.
Yes.
Yes. Okay. So this is probably, you won't say that this is a mid bulb until you are very sure about the proximal film, or you can see the proximal urethra, proximal bulb also, right?
Okay.
Right. So do you know why there is a bulbomembranous injury? Any idea?
So membranous urethra is the fixed part of the urethra, sir. So whenever injury occurs, stretching of the ligaments occur, which causes injury at bulbomembranous junction.
So you think the fixed part has more chance of injury? The prostatic urethra is the most fixed part.
Sir, whenever stretching of the ligaments occur during pelvic fracture, sir, then it causes.
See, this is the part which is not supported by any tissue, not even by prostate or by spongiosum tissue, which is there in the anterior urethra, and in the posterior prostatic urethra, you have the prostate surrounding it, and the non-distensible part, which is more prone to injury, such kind of trauma, right?
Yes.
Oh, go ahead. Go ahead.
Supposing if in a given case of RGU-MCU where you have done it, the prostatic urethra was not opacified, then what will you do?
Sir, we will repeat the MCU-RGU after giving alpha blockers.
So still there is no dye.
Yes.
So then we can pass a bougie from.
Does it happen or not with you? Does it happen or not?
Yes, sir, it happens.
It happens. Yes, it's a very common scenario. Yes.
So in that case, we can pass a bougie from the SPC tracts.
That you will do during surgery, or would you defer it again to see at the time of surgery, or would you like to do beforehand? Practical point.
Sunil, tell me, are you happy or unhappy with this kind of film when you don't see the posterior urethra? Are you really unhappy about this?
Yes, sir. I'm not sure then about the
You're not sure. Yes, you're not sure. Yes, but what can you exclude if you don't see the prostate?
Sorry, sir.
Which type of injury, associated injury, you would exclude with this type of when you don't see a posterior?
Sir, I can exclude the bladder neck injury. Sir.
Right.
That's
so there's a competent bladder neck that you are 100% confirmed now, right? Almost.
Yes.
Not 100%, but yes.
Yes.
Actually, it should make you happy. That was the question that was asked.
So bladder neck injury requires immediate exploration. So if bladder neck injury is not present, so they are difficult to manage also.
Right. So you are happier with if you don't see the dye going down in the posterior urethra or trauma. Yes.
The chances of post-operative continence are better.
Yes.
The chances of post-operative continence are better. If it is open, there is a likelihood that the patient may be incontinent post-operative.
Yes, sir.
So there is another question. What he's asking you: what is gapometry index?
So gapometry index is calculated to calculate the defect and orientation of the
Now, how would it change your management?
Sir, if gapometry index is high, then we need to do more steps of progressive perineal urethroplasty, sir, to align the two ends.
How will you do? How will you calculate the index?
What is the measure? What is the formula?
Sorry, sir. I don't remember.
So it's a ratio between the urethral defect length divided by the length of the bulbar urethra. So it's a very simple logic you can remember, because whenever there is a urethral defect, if you want to bridge that defect, you can only do the anastomosis depending upon the elasticity of the bulbar urethra. You can stretch the bulbar urethra only by 1/3 of its length, not more than that. So beyond that, if you keep on pulling it, obviously you will land up having a quaddy. So this 0.3 is nothing but the 1/3 of the bulbar urethral length. If it is more than that, the defect, then obviously it will have high chance of an elaborated procedure, meaning you might need to go for a inferior pubectomy, bridge the defect. So it is a ratio between the defect length divided by the length of the entire length of the bulbar urethra on RGMC. Okay.
Suppose the index is 1. What does it mean? Sunil.
Yes.
What does it mean?
So it means the urethral length defect is very high and it will be very difficult to.
No, just tell me exact what does it tell you that?
Sir, we will have to do the inferior pubectomy, and we even may need to do.
When it is 1,
we will not be able to do it.
You would not be able to do with even inferior pubectomy.
Sir, abdominal approach we may have to take.
What does it actually mean? That means there is a bulbar urethral necrosis. That is called BUN. That means the whole bulbar urethra is gone.
Yes, sir.
Now you would need probably a transpubic type of thing or something, maybe an interposition tube flap.
Tube flap.
You might require in this. So that becomes a what kind of stricture? What kind of PFUDD it becomes? There are two basic types of PF. One is a simple and other is a
complex.
Complex, right. So this comes under a complex if it is a bulbar urethral necrosis. There are other criteria also that we might discuss later maybe. Yes, go ahead.
Just for completion's sake, the tiles classification which we already discussed, basically it is divided into 3 broad headings. It is type A, type B and type C. In type A, the pelvic ring is stable actually. You have fractures there, but the entire ring is stable. And in type B, most important thing here is that it is vertically stable. There is no vertical displacement of the ring. It is vertically stable, but the ring is rotationally unstable. Horizontally, it is like open book. Such type of fractures will be there. Whereas in type C, the ring is both rotationally it is unstable, at the same time vertically also it is unstable. So here you will have associated injury of the sacroiliac joint also, or you can have the acetabular fracture as well. So as the severity of injury increases, obviously you can estimate from that the amount of impact to the patient at the time of trauma is severe, needing that he might have a very severe urethral distraction as well. So just for an example sake, I kept this X-ray just to show that in the history you should always look for the any orthopedic procedure being done in the past. They might have some screw fixation. Here you can see there is the sacroiliac joint is fixed actually here. So this is also important. This is a type C pelvic fracture is there in that case. Then I think Gaurav has already told that while looking at plain film, you should always look for any stones. Like in this case, there is a SPC where the tip of the catheter is having calcification there. Now, when will you go for an MRI pelvis while evaluating a case of PFDD? Are there any specific indications?
Sir, MRI pelvis basically helps us in seeing the orientation of the two defects, orientation of the two urethral ends. So in complex cases, we can plan for MRIs.
Tell us
So
those
in
situations
complex
where
cases. Now, what are the complex cases? Tell us the
Complex pelvic fracture urethral injury, right?
which you would classify as a complex. What are the various types, or what are the various criteria that these things come under complex? One I've already told you, right?
High gapometry index.
Yes, bulbourethral necrosis, one is. Another thing, it's not just a high gapometry index. Only a high gapometry index doesn't classify it as a complex, right?
So MRI gives you soft tissue, again, picture. Yes. So what are the things which are involved, which you may like to know that before surgery is being contemplated? What else? Any cavity? Any rectorectal fistula?
Yes, if any fistula is present.
And right. Bony fragment also can be seen.
Yes.
And what else?
Crural disc.
Anything else? The corpora can be detached from the inferior pubic rami. Yes. Anything else? You told about bladder neck. You told about anterior urethra. Why are you not saying?
Yes, sir. Bladder neck injury. Yes.
False passages, fistula, rectourethral fistula, etc. All these things would come under a complex. So in that case, you would do a MRI pelvis, right?
Yes.
So now we can. So now we can involve Dr. Shivanand instead of Dr. Sunil.
That's
so
good.
Dr. Shivanand can take over audiovisual on, and you can take over. Yeah.
Thank you, Sunil.
Good evening, sir.
Good evening, Shivanand. So you have heard the history and physical examination and investigation till now.
Yes, sir.
So the next question here is, if the patient has erectile dysfunction prior to surgery, how do you proceed?
We can go for, sir, colored or Doppler of the penis to detail about whether it is vasculogenic or neurogenic.
Okay, so color Doppler will tell you about neurogenic and vasculogenic.
Yes.
G.
What feature in Doppler will let you think of this to be neurogenic?
No, sir. Basically, color Doppler will only tell about the vasculogenic cause of the erectile dysfunction, and if it is not, then most probably it is neurogenic cause.
Okay, so there is no other cause besides vasculogenic and neurogenic.
No, sir. There can be corporal injury, that corporal fibrosis can be there. This can be also.
That comes under vasculogenic. What are the different types of vasculogenic? What are the different types of vasculogenic? One is arterial.
Arterial
one
and venous.
Venogenic, and the other thing is that you call corporal is, what is that? That is not vein, that is not artery.
Yes.
What is it? It is veno-occlusive dysfunction. All right.
Okay.
Yes, so it could be psychogenic also. It could be veno. If the patient has erectile dysfunction before surgery, it could be patient may be having before also ED. It could be hormonal cause also. It could be so many other things.
Yes, sir.
So why are you just thinking in terms of only vasculogenic? And then the penile Doppler is a very, very kind of thing which is may have fallacious results. A patient who is very anxious will have very kind of different kind of may not have a normal results, even if everything is normal. So you can't depend totally on penile Doppler study. You have to clinically correlate it with, and later you have to confirm it with other investigations. Right? So go ahead. So how would you evaluate ED? Yes.
So do you think that always you need to go for a pharmacological induced penile Doppler evaluation, or just you can give some drug to say that, to look for his erection? Because bedside, if the patient is saying that I'm not having nocturnal erections, So one simple thing which you can do is offer him a PD5 inhibitor, and if he has good erection with that, that itself rules out your vasculogenic ED as one of the cause for ED in this case. So that is a simple test to do before going for an invasive procedure like pharmacological induced penile Doppler. Okay.
So that is also called office sildenafil test. Sometimes we do in ED evaluation very routinely, right? So here it may not be office, it may be at bedside. So
the question is, why do you want to evaluate the ED?
Yes.
What is the role? Why do you want? What is your interest? And yeah, I know the patient will be taken care of. The ED can be taken care of later on. But why you are interested in evaluating the erectile dysfunction at this moment?
We can counsel the patient that we are operating for the urethral stricture, not for the erectile dysfunction, and your erectile dysfunction was present before the surgery.
Okay, so the patient may tell you that your surgery have caused erectile dysfunction. So it is very important to counsel the patient. Yes.
Anything else in prognosis of outcome of stricture?
Yes, Dr.
Have you
Singh
got
has
anything? Are you aware of any literature? It might have some reading in the outcome.
If erectile dysfunction is due to arterial cause, then there is a less success rate for the urethroplasty.
Maybe, may not be. Okay.
Which type of arteriogenetic?
If there is arterial stenosis type, sir.
One side, unilateral, bilateral? Which artery?
Bulbar arteries.
Bulbar artery.
Bulbar
artery you are going to divide at the
dorsal penile arteries.
So again, there comes how many arteries are there for penis?
Basically, dorsal injury to the dorsal penile artery lead to the
dorsal penile artery.
Which artery supplies the corpora? Is it erectile dysfunction due to the spongosa, again blood supply of the spongosa or bulb or glans, or is it due to blood supply of the corpora? Now see, now here the examiner will become alert to know the anatomical knowledge of the candidate. What is the blood supply to the corpora? Where does it come from?
It arises from the common penile artery. Cavernosal artery supplies it.
Okay, so internal pudendal artery gives a last terminal branch of this common penile and perineal. Common perineal gives 3 branches. Tell me 3 branches.
Cavernosal artery, urethral artery, and dorsal penile arteries.
It's dorsal penile. Okay, dorsal artery of the penis, right? And cavernosal and bulbourethral. Yes. So what is your final diagnosis?
Sir, my final diagnosis is PFUI, and it is a simple type of PFUI.
Okay. So
what do you mean by complex?
What is complex PFUI?
If there is associated a perineal injury or a perineal scar, or a there is any associated fistula, is there is any bladder neck injury, then we can say it for a complex PFUDD.
If there is a sinus,
Yes,
sinus,
sir.
not a fistula, then
it is also come under, sir, complex PFUD.
So we already discussed it just a couple of minutes
before. MRI, yes.
The cavities, sir has told you the cavities, the fistula, the sinus, the rectourethral fistula, bladder neck injury, anteurethral injury, the larger defect. So all these would come under, right?
So associated
and a redo case and a bladder urethral necrosis, all this will come under complex.
Okay.
Okay.
Failed urethroplasty also.
This is just to show a few photographs of lengthy defects. And one thing which important thing is, whenever you're looking for RGMC, you should always look for the contrast leak into the rectum. That is very important. which you should take care. And this is a case of RGMC with an antiurethral stricture, associated antiurethral stricture was also there. You can see the entire bulbar urethra is not, the lumen is narrow here. So now how will you manage this case now? What procedure you want to do? How will you go about
So
it?
this is a simple case of PFUI, right?
Sir, I will manage by end-to-end urethroplasty, sir.
No, so now, it's this moment, examiner will like to know the steps taken by you just to see whether you have been watching or you have been watchful. Do you remember how to do a case of urethroplasty? Such case as PFUDT.
So again, what is a better term than end-to-end urethroplasty? So this is, you don't say end-to-end urethroplasty. What is the term usually used? It is a progressive perineal urethroplasty, PPU, right?
PPU.
Yeah, and
So
there's a
how
term
do you
called
proceed?
PAMA also.
Yeah.
Yes,
How do you
abdominal.
proceed for
And-
PPU?
And it's a bulboprostatic anastomosis.
Right.
It's a bulboprostatic anastomosis.
So
Yeah, so
how
you
do
now say the patient had been taken inside the operation theater because if the time permits, which I think maybe another 5 minutes we can go, 5 to 10 minutes. So now in that situation, can you tell me how we proceed for urethroplasty, PPU? In this case, patient has been
Okay,
taken inside the operation theater. Yes.
Patient in extended lithotomy position, a midline incision in the perineum from in the perineum.
So
And,
would you like to do scopy or not? So just see again, I'm just asking you, what are the steps when the urethroplasty is being done by any surgeon or PPU is being done? Have you ever seen what are the steps being taken? Patient has been draped. Then what did you do? Do they assess it endoscopically or no?
Yes, sir, we assess it, sir.
is it
So, no, but
important
you
or
are
not?
forgetting it.
Is it
Yes, sir.
important?
You must
Even
tell
after
all these points.
you, is it important or not?
Yes, sir, it is important, sir.
Right. So you will assess both the anterior urethra and the posterior urethra, right? Yes. So there many times RGU can miss the dilated posterior urethra, right? So it's very important. Good.
One question, very practical question. When you are doing retrograde, I will say that endoscopy through the suprapubic tract, what you are looking for? What do you want to see?
Sir, we want to see the bladder neck, coaptation of bladder neck, and by retrograde, by antegrade scopy, we can see up to the Veru, sir.
What else?
So now again, I'm telling you aim, objective of anything. Would you like
We
to
can
see
also,
any stone lying in the bladder?
yes, sir.
Because the
We
X-ray,
will
it
first.
may not be seen in X-ray. Whatever investigation you have done, the stone may not be seen.
Yes, sir.
And-
First of all, we
Yeah.
evaluate the bladder. Is there any diverticular calculus? Is there or not?
Okay, how do the patient, if you have forgotten that the stone you didn't wanted to see, just you went through the neck and you have seen, okay, it is up to the verumentanum because you have to do ritual and you forgot to see there was one stone left out. How this patient will present to you now? You have done urethroplasty. Can you
Yes,
tell
sir.
me the surgeon, an experienced person, can make a diagnosis? What will happen to this patient once you have removed the catheter, peritoneal catheter following surgery? You are very happy because you are very quick. You went through the tract, you saw the bladder neck, you saw the urethra, you came out that because that was the ritual you have to do. You didn't care for the bladder stone. Now the bladder stone was left out. It was around 8 mm stone in the bladder. Now you have removed the catheter. What will happen?
It can cause a retention of urine, sir.
So you have removed the catheter, patient will you not able to void? What does it say? Says?
Don't know, sir.
Okay. So can this stone fall down? The patient had voided once or two, very good stream. And then suddenly he came, oh, he's not able to void. He's having that. So what could be the reason? Can you tell me the reasons for that? Patient voided 1 or 2 acts of micturition. He was very happy. Has again distributed laddu to the friends, and his family enjoyed. And now he brought 1 packet for you also. And then in the night he called you. I'm not able to void. So what could be the reason? One, you have left out the stone which shall fallen down, right? And
Yes,
got
sir.
stuck in the urethra, retention. Anything else? Do you think anything else as a cause?
I think we can, sir. I think we need to.
Yeah, right. Okay. False passage?
False
Yes,
passage.
sir.
Yeah.
Right. Can
So
it be? Yes, right.
Yes,
Okay,
sir.
so
Yes,
I
sir.
think
It
Dr.
can.
Sudhir has prepared some slides. We'd like to again share with you. Okay, right.
As I suggested that whenever you are doing antegrade scopy, also whenever you are looking for the bladder neck, you need to look for any other associated false passage. Sometimes you might have a false passage just by the side of the bladder neck. So it's rarely cases people do the anastomosis to the false passage as well. So it is very important to look for that. So you didn't tell us the main steps of progressive perineal urethroplasty, because since we are running time, I am rushing it fast. So there are the photographs which I have kept. This, like, you can go for a vertical midline incision or a lambda shaped incision. So after opening the after giving the incision, then you'll go to the bulbospongeous muscle in the midline. You are going to cut it. Then mobilization of the bulbar urethra, that is the next step. And then after you mobilize it, of course, if you need to bridge the gap, you can go for crural separation. Then inferior pubectomy in some cases when the defect is still longer. Like in this case, you can see the periosteum which is opened up, and then the inferior pubectomy. After that, excision of the scar is the next most important step, which is the most common cause for recurrence. So scar should be excised until you have a pink supple urethra proximally, and then the anastomosis. So can you tell us the complications of progressive perineal urethroplasty? Just enumerate the complications of this procedure.
Hemorrhage can be there.
So classify them as
intraoperative,
early and delayed, right? So intraoperative.
Intraoperative can be hemorrhage, injury to the.
So injury to which?
Hemorrhage. How frequently is blood transfusion required in this kind of a situation?
Hemorrhage rate is around, sir, around 5%, sir.
Did you
Injury
notice
to
what was his pre-operative HP? Do you remember in this case? I think it was 14.8. I think it was 14.8. We can go back a few slides and see, but
right. So hemoglobin was normal in this patient, yes.
Injury to the rectum
and
injury to the bladder neck can also occur.
Blood transfusion is very rarely required in these cases. So hemorrhage is not actually the most important complication. When you're talking about complication, hemorrhage as the first complication is not the right way of beginning the list of complications.
Very good.
At least in intra-op, you would not say that, right? Yes. Anything else? Can you injure the anterior urethra also?
Injury to
How
the
do you injure anterior urethra while doing urethroplasty?
Sorry, sir.
How do you injure the anterior urethra while doing urethroplasty?
So if you know the steps, then you can tell. At what step, how can you injure anterior urethra? That is the question.
Sir, during dissection and mobilization of the bulbar urethra, we can injuries.
Right. At that time, what else? Can you create a false passage in the anterior bulbar urethra? And how does it occur? A very common thing that usually many of us would be doing and can cause if we are not very careful. How do you see the anterior urethra, the lower end, the distal? How do you see it? By putting a dilator?
Yes, sir.
Yes.
Putting a dilator or putting a catheter, sir. We can
Right. So
see.
that's
which
why
one?
you put
Which
a
one?
catheter, not a metal dilator. You can damage create a false passage also in the bulbar urethra while putting a metal dilator.
Yes,
Right?
sir.
So I think go ahead, Sudhir.
Yes, complications specifically to this procedure are like injury to the anterior urethra. Yes, rectal injury can occur. It's very important. So always, whenever you are doing this procedure, it's all whenever you are close to the rectum at the proximal bulbar region where you are dissecting, it is a good habit to put a finger in the rectum to prevent that injury. So this is very important. And then the injury to the corpora cavernosa can occur, and early complications. You always, whenever you are telling in exam, you should say that intra-op early and delayed complications. You didn't utter anything in the post-operative period. Yes, sometimes you can have bleeding, wound infection. Of course, whenever you do any urethral procedure, patient can develop epidimarket. It can occur. And the delayed complications involve the restricture, which is around to the tune of 15 to 30%. And then sometimes, yes, Singh sir has already said that whenever a patient he doesn't void after removal of catheter, immediately if he goes into retention on the same day. So one of the important thing is anastomosis to a false lumen. That's why intraoperatively, whenever you are anastomosing, it is a good habit to do before anastomosis, after taking the sutures, to do a scopy through that opening to see whether you are able to see the veru or through that lumen, and whether you are anastomosing into the right lumen or not. That is a good habit to do. So then of course, erectile and ejaculatory dysfunction and incontinence, if there is associated bladder neck injury before, then that can happen. So these things are the most common complications which you should look for. So what is your post-operative care after doing surgery in this case? So how will you, and also the follow-up? I think we can wind it up like post-operative course and follow-up.
Yes.
Sir, in the early post-operative period, bed rest for the 2 days, along with the supportive medication. We also give the anticholinergic, and drain is removed in the POD 3. And first of all, 21 days, we perform
So don't see that the drain is removed on third day. Every case you would remove, even if there is a blood coming out through the drain.
Definitely, sir. We will not
Or if
remove
there
on
is
day
suppose
3.
an anastomotic leak and the urine is coming out. So don't be very with fixed ideas. No, you have to be individually. You have to see, right?
Even some people don't put drain also.
Even though they may not put the drain at all.
Drain is not a must.
Right. So when would you remove the catheter?
On POD 21, sir.
Every case?
Not every case, generalized a POD 21.
How do you decide?
If it is a easy tension-free anastomosis, there is no complications, then we can remove down POD 21, sir. If there is a
anything you would do to confirm that your anastomosis is
yes, sir. We do perform a dye test before removing the catheter, sir.
No, see now what Dr. Siva wanted to hear from you. Can you tell me the name of this study done? Now you are telling dye. That's not good. You should tell the
forgetting the
procedure.
name, sir.
Either you can say micturating cystotrogram, or you can tell pericatheter RGU.
Pericatheter
Pericatheter dye test, sir.
Right. So many people would do it after 4 weeks also, right? Because they do not want to do every case a pericatheter urogram. So to be more safe, they would do it 4 weeks. Yes. So when would you remove the SPC?
If after removal of catheter, patient micturates and we go for a uroflowmetry, its flow rate is good, then we can remove the SPC after 7 days, sir.
So every time you would do a uroflowmetry in this patient. So
uroflowmetry test to just confirm the
So if the
what
patient is
patient is
saying
saying.
that he is very comfortably passing urine in a very good stream, wide caliber urinary stream, still you want to do a uroflowmetry? Okay.
No,
Not necessary, right? Not very necessary, unless his patient is saying that he is having some thin caliber or is a weak stream, then only. Immediate
So
course
he
of
want
right. How would you
he
do a
want to
follow-up?
define success.
How would you do a follow-up? So you've removed the SPC. How would you follow up this patient?
We will advise for clean intermittent catheterization, sir.
Okay. Every patient
You will
would
keep him for clean catheterization. When you are 100% sure that you have done good thing, good job. You know, when the patient requires any assistance, means is a failure of the procedures.
you will create false passage. You will even destroy your whole surgery if you ask him to do a CIC immediately after removing the catheter.
Not in all cases, sir. If there is.
So, do you have a regular practice of doing a CIC after end-to-end urethroplasty?
No, how to
No,
define
sir.
success? So you should learn the success, how to define success, and how to follow up these cases. I think you must read it. And when you are now assisting and managing the case in your center, please learn all these points from your consultant. You can ask those queries. You have some curiosity. Always think, yeah, how can you again satisfy your curiosity? How can you learn more and more? I think, yeah. So, Dr. Noop?
Never do a CIC immediately, right?
Yes.
And then you have to be very close follow-up, at least 2 weeks, 4 weeks, so that even if you have a stricture, you would be able to know the patient is developing a stricture, right? So the follow-up is very...
Yeah. Dr. Sudhir, you have more slides?
I think almost we have covered the main point. I think we can wind it up.
Okay. Right. Yeah. So you should learn. So what you should know how to define success, what are the ways, and then how to follow up these patients. That's very important. But same time, the advice is, as Professor Shivam has told you, yes, never tell CIC the treatment for a patient of PFUDD following urethroplasty. Right. So some learning point for you. Yeah, he has made it.
Fastly cover a few points. You should, I mean, just for learning point of view, yes, obviously these patients you need to follow up with a uroflowmetry whenever they visit you, and if they are symptomatic, you need to evaluate him. If they say that they themselves are complaining that their stream has decreased, then definitely you need to evaluate them. At that point of time, you can do a calibration, but not as a routine. Calibration should not be done because you can injure the anastomosis which you have done, because there will be a angle there. Obviously, you have recently done a surgery, so it would be more harmful actually. So then you should always know about early versus delayed repair. This would generally be an exam question which keeps on coming up. So the critical appraisal of early versus delayed repair of pelvic fracture urethral distraction defect, and why people prefer a delayed repair. Now, if you go through the AUA guideline, they clear-cut say that delayed repair should be the standard of care in operating these patients, because it has few advantages like stabilization of life-threatening injuries at the point of injury. By the time you operate in a delayed setting, the orthopedic injuries might have healed, and also the absorption and resorption of the pelvic hematoma might have occurred by that time. So a scar will also be stabilized by that time, so you can do the proper surgery after that. Then always this question also will be asked in exam, and you have an associated anterior little stricture is there, so which is a complex PUD, how you are going to manage. So obviously you need a pedicle or vascular based free flaps you need to use to bridge the defect in such scenarios. And this question is also a common question which is asked, how PFDD is different in children compared to adults. So obviously they have long since the prostate is not well developed, the defects would be longer, and the associated bladder neck injury is higher, and those are the most important points for that. So, and another classification of the RG which is done at the time of injury, this you should everybody should learn this. Gallup-Hinton and McCallum classification, type 1, type 2, and type 3. and then the Goldman classification. These two classifications you should have in mind, depending upon the severity of the urethral injury, how to manage them. So that's it. I think erectile dysfunction we have anyway covered it, sir. Thank you. Hello.
Yes, yes.
That's it, sir. Not your Anup sir, your voice is not audible. Hello.
Okay, thank you, everybody.
Yeah,
Thank you. Thanks all residents. We might have be a little harsh, so just excuse us. This is the way usually an examiner does.
That's, you say harshness is always blessing for them. Yes, so they will remember it. They are awoken. Yes, right.
So thank you all our esteemed teachers, Dr. Singh sir, Dr. Seth sir, Dr. Shivam. They have taken out their precious time to teach you. You should feel yourself.
Actually, Dr. Anup, just only one point I would like to tell. I don't know.
Yes,
These
sir.
have become just incidental. S, Singh, Seth, and Shivam. Yes. So that is called success for the student. Again, another 2 S added. Success to the student. They 3 people have added to success of the student.
Let's see whether they succeed or not. Let's.
I think we wish success. Okay, now to Dr. Anup.
So I also want to thank Mr. Navneet and his whole team who has helped us in all these online programs. And I hope our students have learned a lot, because you are going to face one of these teachers as one of your examiner. So you have got now the taste of their questions, and I hope you will answer them well, and you all will be successful. So best of luck to all of you for your exams, and we'll have 2 or 3 more sessions before your final exams. Thank you everyone, very much, and have a great evening. Thank you, sir.
I should keep everybody busy and fruitful evening. That's good. Okay, no, bye. Bye.
We have moderators with S also.
Thank you very much.
Yeah, moderators. Yes, they have done great job. Yes, good.
Okay,
Yes,
thank you.
Bye. Bye.
Thank you, sir.
Bye, Shivam.
Bye, sir.
Bye, Dr. Bliss. Bye. Again, see another Sudhir. वो भी नहीं देखा ऐसे कौन ऐसा गया?
All S. Nothing.
अब देखिए उधर भी.
Sanjay, Surekha, and Sudhir.
सुरेखा भी आ गया. देखिए ध्यान